So picking up where we left off, so there are some pathogens that can infect the baby during pregnancy and also during birth. Probably the one that stands out in terms of pregnancy is the organism that causes syphilis, because this can actually cross the placental barrier. So the baby can actually be born with syphilis. There are other diseases that where a C-section is warranted. One of these is a syndrome called TORCH. So TORCH is toxoplasmosis, which is the protozoan disease that people would tend to associate with cleaning cat litter boxes during pregnancy. Rubella, cytomegalovirus, herpes simplex 2. If any of those are present, then mom wants to avoid a vaginal birth and actually go for a C-section. So one of the things that matters too as to whether infection or disease it develops is the size of the inoculum. And what that refers to is the quantity of microbes in the inoculating dose. So imagine if someone is infected with some type of respiratory virus and they sneeze on you. So what would it take in terms of the number of viruses that actually then you breathe in for you to start to develop an infection and then a disease? So infection will only proceed if something called the infectious dose is present. And in one of the sheets that I also attached in the module for the PowerPoints for the last unit, is a definition. So ID 50, which stands for infectious dose 50, is the amount of inoculum of that pathogen that would be required to make 50% of the population sick. And when we have microorganisms that are more virulent, that means that you require few of them because they're so good at getting into cells and then causing an infection. So the more virulent the organism is, the smaller infectious dose that is necessary to actually overcome the patient's immune system and get in there and cause an infection and start the whole process. So first you have to encounter that pathogen, however you happen to do that, whether someone sneezes on you, if it's a virus and you touch a surface and then you touch your face, if it's still a respiratory route, you get food poisoning, something like that. First it has to gain entry to you, and then it has to go through attaching to your host cells. So just because it makes its way into you doesn't mean that automatically, okay, boom, it's inside you, it's definitely going to cause infection. You have certain barriers that prevent that, which we'll talk about, I think, first thing in chapter 16. But also realize that if it's bacterial, it has to adhere to your host cells. And so it can do that in a couple of mechanisms, whether it's the fimbriae, which remember are like molecular Velcro, or if the bacteria has a really thick capsule, which makes it nice and sticky. When we talk about a virus, the main mechanism are those spikes that fit in the lock and key mechanism. But that's the first step. It has to encounter a host cell, and it actually has to adhere to the host cell. So I also want to mention that sometimes it's not the living bacteria itself that is causing damage to your cells. Sometimes it's something that is produced by the bacteria, and namely toxins. So what this slide does is it gives you some basic vocabulary talking about toxins. So toxigenicity just means whether the microorganism produces toxins, and not all microbes do, thank God. A disease that is caused by toxins are toxinosis, and toxemias and intoxications vary in that if the disease is a toxemia, it means that the toxin is being spread by the blood from the site of the infection. So think, for example, you step on a rusty nail that happens to have the bacteria that causes tetanus, which is a toxin-producing bacteria. So the toxin is spread via the blood from the puncture wound from that nail. If it's something that you ingest, we refer to it as an intoxication. And an example of that would be botulism toxin, which can happen in contaminated food and potentially spread to water supplies. When we talk about how the bacteria produces the toxin, that is these last two terms. So an exotoxin means that the cell is alive, it's manufacturing the toxin, and then it secretes it from the cell into the bloodstream or wherever it happens to be. An endotoxin is a toxin that, as long as the bacteria is alive, it's not released. But if the bacteria dies and the cell wall starts breaking down, the toxin is going to be released because the toxin is actually embedded in the cell wall. And I believe I mentioned this previously in the semester, but this is something that is specifically found in gram-negative bacteria. And it's really kind of an insidious mechanism because it's basically, hey, as long as you don't kill me, we're good. But the minute you treat the patient with antibiotics and the gram-negative cells start to die, then it releases this endotoxin, and that can cause the patient to go into shock and actually die from it. So yeah, it's a pretty nasty, way to use a toxin, basically. Okay, so exotoxins, just to reiterate, the cell is alive, the cell is producing and manufacturing toxins, and then it's secreting them. And these toxins, yeah, they do tend to affect the lungs and the heart. In gram-negative bacteria, here we have the endotoxin that it's built into the cell wall. Everything is fine, nothing's being secreted as long as the cell is alive. But once you start to destroy that gram-negative cell and the cell wall starts breaking down, then the toxin is released, and that can cause the patient to quickly go into shock. Okay, the only thing I want you to get off of this slide, because we've kind of, talked about all of these things, but the term necrosis means that tissues and cells are now dying. So that's kind of the worst case scenario. When you think of gangrene, when the tissue actually starts to turn black, that means that tissue is dead, and we need to get that out of there, because when tissue starts dying, it starts releasing toxic compounds. So the prefix necro means death. So yeah, necrosis is pretty much the worst case scenario in terms of getting a microbial infection and disease. So on here, I want to show you some examples of different infections, and these are also on a worksheet that I've attached under the Unit 4 PowerPoints module. So let's go through these. Kind of, least, severe to worse. So a localized infection is when the infection is just kind of walled off, and it is in one area of the body, and it's not spreading through the bloodstream. Okay, so for example, if someone had a boil or an abscess, and the infection, you're going to have pus there, but that can be drained and you can treat it with an antibiotic. That would be an example of a localized infection. Going to the other extreme, the worst case scenario is a systemic infection. And what that means is that now the microbe is everywhere because it's in the blood. And you can't, just have the bloodstream go to one organ and then that's it. Once something is in the blood, it's going to be carried everywhere systemically in the body. And so that's why that is kind of the worst case scenario. So yeah, you want to try to avoid that. A focal infection is where the primary infection starts off as a focal infection, but then either the bacteria or some products of the bacteria travel to another organ, and it tends to be a specifically targeted organ. So the best example of this is strep throat. So strep throat, remember, is caused by Streptococcus pyogenes, beta strep. Okay, so that's when you hear group B strep, that's the strain that is causing strep throat. But what this bacteria tends to do is it starts off in the throat, okay, and causes strep throat, which is painful and certainly not fun to endure, but not deadly. But then for whatever reason, the bacteria tends to travel to the heart. So this is why strep throat needs to be taken really seriously, especially in pediatric patients. In adults, when we get strep throat, we can usually tough it out without antibiotics, and our immune system step up and take care of it. But in little kids, remember, their heart valves are not fully developed yet. And what the bacteria will do is it will attack those heart valves and damage them during development. It won't do this in adults because our heart valves are already fully formed, and so it's not going to hurt them. It's needed to do that during the development. So yeah, strep throat in pediatric patients is definitely something that you want to get on top of that and usually get antibiotic therapy. Okay, this one I want to mention because I've talked about this a couple times in diagnosis too. Remember that just because, in this class, we tend to study one category of organisms at a time, you're going to have a lot of patients come to you, and especially those that are older and more immunocompromised, having mixed infections. So they might have an infection, multiple infections caused by a gram-positive and a gram-negative bacteria, or perhaps they started out with a virus and now they have a secondary infection caused by a bacteria. You can have bacteria and fungi, pretty much any combination. So this is why, you can only treat a patient and prescribe based on the signs and symptoms that you see. But once again, you don't have a crystal ball, and mixed infections are really common. So, sometimes the patient has to come back and say, what, I think I've gotten rid of one problem, but I'm still feeling sick. And normally that means, okay, we're dealing with a mixed infection. And then we've talked about this before too, where it is, what we call either a secondary, an opportunistic infection. So let's say you have a female who has a UTI. They're treated with antibiotic therapy to get rid of that. But guess what? It screws up the microbial antagonism, and now you end up with a yeast infection. Or if it's a narrow spectrum antibiotic, you kill off all the gram negatives, say, and now the gram positives can overgrow, and so you end up with a secondary infection. So antibiotics are great. We definitely need them, but there are certain types of infections that come along with their treatment, that can be problematic, and you just want to be, certainly aware of them. So I previously mentioned in the previous slide talking about signs and symptoms. So let's go through this. Oh, sorry, take a sip of my beverage. Okay, so a sign is any objective evidence of disease as noted by an observer, okay? And what this really means is, first of all, objective is, black and white, fact-based. Subjective means it's more of a gray area, and it's something that's not fact-based. It's like feelings. Like I feel nauseous, my head hurts, and if you give them a level on a pain scale, one person might say 3, one person might say 9, because we all have different reactions to pain. So a sign is anything that you, as a healthcare provider, can measure yourself. Okay, and I'm going to give you some examples of these. A symptom is something that the patient has to tell you about, and it's much more subjective. And this is why good communication skills are incredibly important in healthcare, because you really want to establish a relationship with that patient so that they feel comfortable to tell you their symptoms, especially, if it's something that the patient might feel embarrassed about and, they really don't want to talk about it. But you have to have all the information, and that means, you can only measure what you can measure, and you can only treat symptoms that the patient is going to tell you about. So that's why it's important to put patients at ease and really develop those good communication skills. Okay, a syndrome is when you have something that's much more broad-based, and there's a certain complex of signs and symptoms that go together. So, for example, AIDS, okay, acquired immune deficiency syndrome. There were lots of signs that went with that, such as Kaposi's sarcoma, which is a certain type of cancer that would be evident on the skin. Night sweats, chills, which are symptoms. So it's much broader based. So here's some examples of signs versus symptoms. So signs are things that you yourself can measure, but it's also things that are lab-based. So it doesn't mean that you have to do the test, but if you're given a lab report and it gives you findings, that also counts as a sign. Okay, but obviously you can take the temperature of the patient, you can listen to their chest, you can examine their skin, palpate for swollen lymph nodes, listen to their heart rate. Also, lab reports can tell you, we have microbes present in the tissue fluids. We have a difference of white blood cells, and I'm going to hold off on these terms because we'll get to them soon. You can look for the presence of antibodies in the patient's serum. So anything that you physically can do and listen to, observe, and then also any test results. Symptoms are things that the patient has to tell you. So, my chest feels tight, malaise and fatigue are just kind of, I don't have any energy. Unless a person is vomiting in your office, you're probably not going to be able to look at them and say, it's obvious that you're having nausea, or it's very obvious to me that you haven't been eating. Okay, a patient has to tell you those types of things. Have they been having night sweats? Do they have soreness or irritation in a particular area? Because once again, you don't have a crystal ball, so you have to rely on the patient to tell you these things. Okay. I'm going to skip this slide because we are going to get into inflammation a lot in chapter 16. Okay, so I'm just going to hold off on that. So do not worry about this slide. So I'd mentioned those terms, leukocytosis and leukopenia. So here are some signs of infection in the blood. And in chapter 16, we're going to talk more specifically about the different types of white blood cells and what this means. But basically, when a patient's blood is sent to the lab and they're going to measure, how many red blood cells, how many white blood cells, how many platelets. So if you see an increase in the total number of white blood cells, that indicates a condition called leukocytosis, and that indicates that the patient is fighting some type of infection. And then when you actually look at the different types of white blood cells and where those numbers are increasing, that can give you an indication, this, is likely viral, or this is a bacterial infection, or, a parasitic worm infection. But you're looking for a general increase in the number of white blood cells. So typically a patient who is not experiencing any type of infection would have between 4 to 10,000 white blood cells per cc or milliliter of blood. So if you see an increase in white blood cells up to, say, 15,000, 20,000, 30,000, that indicates to you, there's some type of infectious process going on. If they're way up to, nearing 100,000, then that is usually the realm where it's some type of bloodborne cancer, such as leukemia. And normally, by looking at the cells under a microscope, when you're up to that level, the cells don't look normal, and that indicates, we probably need to look in the bone marrow to see what actually is going on. Okay, leukopenia is the exact opposite. So this is where you see a decrease in the number of white blood cells. So maybe there's only 1,000 per cc. So that can indicate conditions like aplastic anemia, AIDS or HIV, active HIV infection. Perhaps the person has a genetically based disease that's affecting their number of white blood cells. But leukocytosis and leukopenia are the opposite. Okay, one's an increase and one's a decrease. We've also talked about sepsis. Okay, I want to differentiate that from a bacteremia or a viremia. So the suffix emia simply means that it is present in the blood. So can a person have a bacterial blood infection? Yes. Does it mean that they're septic? No. Okay. Same thing with viruses. So the difference is when a person is septic, not only do they have microorganisms, and it can be one species or it can be, several species of microorganisms, but the key is they are actively multiplying in large numbers. So if you were to do, take blood at 6 in the morning and then again at noon, you're going to see a significant increase in the number of microorganisms present in the blood. Okay, bacteremia, you probably would not. So that's the difference between the two. And obviously this is much more critical, and much more dangerous in terms of, okay, we need to act on this right away. I'm not going to really mention this because, this is one of the things though, actually I do want to mention it just in terms of COVID-19. So can people be infected with COVID-19 and be completely asymptomatic? Absolutely. And that's the scary part in terms of the spread, because, they're not having a cough or a fever or anything that indicates they might be infected, but they could be. And either they're able to fight off the virus or themselves because they're young and healthy, or it hasn't developed yet. The virus has not multiplied to the point where it's actually causing damage to lung cells. The dangerous part is that because this is a respiratory virus, they can absolutely be carriers at this point and spread it, whether it's onto objects, say at the grocery store, or, coughing and talking and being close to people. So they're basically carriers, okay? Kind of like Typhoid Mary, think of it that way. Maybe we have COVID Barry or whoever, but asymptomatic infections, the person can actually be carriers. Now, are you going to see asymptomatic people coming to your office for treatment? No, because normally most people, they have to be feeling sick and uncomfortable to the point where they're actually going to take time and then go to urgent care or make a doctor's appointment, unless they're just there for a physical. So yeah, most of the infections that you're going to encounter in people with patients, there's going to be some sorts of signs and symptoms to let you know that they need to be treated. Okay, I'm going to stop there because we're up to 22 minutes. One more video and then we'll be completely done with chapter 14, 15. Thank you.